On behalf of the IU Health Bloomington Hospital Medical Education Department, I would like to thank you for attending today's medical lecture. Today's presentation is Behavioral Health Therapy to Children with Autism by Dr. Breanne Hartley and Dr. Stephen Merahn. Dr. Hartley and Dr. Merahn practice at UNIFI Autism Care in Carmel, Indiana. At the end of the presentation, Dr. Hartley and Dr. Merahn will gladly take questions via the chat box or by muting your mic to ask a question. I will now turn it over to Dr. Hartley and Dr. Merahn.
Thank you. Give me 1 second and I'll put my share in place. And here we go. All right. Thank you all for attending. We're going to get started. Just a little bit about me. I am a pediatrician by training, trained at the Einstein Montefiore campus in the Bronx. Spent the first 7 years of my career with the New York City Health Department, largely focused on early childhood issues. I am the former chief medical officer of a national autism services provider. I'm also a member of the autism subcommittee for the American Academy of Pediatrics Council on Children with Disabilities, and on the primary care committee for the section on developmental behavior pediatrics. And the only physician, interestingly enough, I wish there were more of me on there, on the Autism Commission on Quality, which is an organization that was founded by the Council of Autism Services Providers, which is actually where I met my colleague, Dr. Hartley, and our relationship began when we both sat on that standards committee. Breanne?
Yes, I am so grateful for that committee because I'm glad that it brought Dr. Merahn and I into the same orbit. I'm Dr. Breanne Hartley. I'm a board certified behavior analyst, or BCBA, with training in psychology. And I understand that perhaps for some of you, the credential BCBA might be a little unfamiliar. So I'll just share briefly that that credential helps in identifying that I'm a healthcare professional who uses the science of behavior to assess, design, and implement individualized interventions that improve socially significant skills and reduce challenging behaviors, oftentimes for individuals with autism, which we'll speak much more about throughout this presentation, but also for individuals with other developmental disabilities and challenges as well. So I've been working with children with autism and their families in clinical settings for over 20 years. I currently function as the president and chief clinical officer of UNIFI Autism Care, where we're really passionate about the need to integrate the expertise from medical professionals such as yourself into the work that we do with children on the autism spectrum. And that perspective, that integration of both the behavioral care and the medical expertise and all of that collaboration is really largely due to the oversight and advisement of Dr. Merahn for UNIFI. And so we've been really happy to be able to adopt this whole child health perspective within the way that we approach treatment. So of course, that's really a big theme of what we'll be talking about today. And I'll just add one additional note about myself and my background. So in addition to my role at UNIFI, I also function as the president of the board of directors at the Behavior Analyst Certification Board. And what that is, it's the entity that oversees certification and maintenance of the credentials for those who are implementing applied behavior analysis. So board certified behavior analysts and registered behavior technicians. So I'm really proud of the work that I do in that capacity to really help shape the future of the profession and the work that we'll largely talk about today. So happy to be here, and I'll throw it back to you, Dr. Merahn.
So two quick comments. Number one, the BACB, the Behavior Analyst Certification Board, is the equivalent of the American Board of Pediatrics for the behavior analytic community. And the other, I'm glad Breanne mentioned the issue of clinical integration. You know, when I first began working in the autism services space and learned more about behavior analysis, it was clear to me that there were applications for behavior analysis that really went well beyond just treatments of autism. The study that really kind of showed me the possibilities here was a very powerful study that showed that applied behavior analysis actually works with children with Prader-Willi syndrome, which you all know is a major struggle. And I began to look outside, and we'll talk about this in a little bit more detail later. Um, Even things, and this is part of this, the kind of the idea of clinical integration. For many children with autism, even an office visit can become complicated. There's behaviors, reactions to behaviors, the need for venipuncture or vaccine administration, or in some cases, perhaps an MRI or other tests, and there's or dentistry, for example. And behavior analysis is not just about focused on autism symptoms and behaviors, focused on behavior. And all health-related behaviors, or as I'm increasingly saying, behavioral determinants of health, are really an area where I believe in medicine we could use some assistance. So we're going to talk. The first part of this presentation today is really going to focus very much on autism specifically. The slides are very wordy, so and that's because we want them to be a handout. So I'm not going to read the slides directly. We'll kind of summarize and talk a little bit about the point we want to make with the data on the slides. We're going to begin with autism, and then Breanne's going to take over and talk a little bit about behavior analysis and its applications, perhaps outside of autism. So, we're learning more and more about what is increasingly a neurodivergent population, and whether it's autism or learning disabilities or ADHD as a form of neurodiversity. We tend to think about child development, particularly around the ages and stages issues, as having, a lot of commonalities. But the fact of the matter is we're learning more and more, particularly as we dig into some of the genetics of neuropsychological function, not necessarily neuropsychological pathology, but neuropsychological function, that there's tremendous differences between the way people process information. And one of my favorite ways of expressing this is actually my daughter Leah, at age 6, talking to her brother, who happens to have a colorblind. We were sitting at dinner one night, and Leah says, I wish I was colorblind too. And her mom and I were like, well, what? Why? And then she actually said, because then I could see the world the way Ellis does. And while Ellis is not autistic, but Ellis does have a neurodiverse condition. And in some cases, that neurodiverse condition can create some functional limitations. For a long time, there was the perception that certain types of colorblindness had limitations to driving, for example. So there's a functional limitation that can be associated with colorblind. I can tell you, my son's 19 now, and sometimes he puts color combinations together in the clothing he's wearing that clearly shows he has a couple of functional limitations. But we like to look at the issue of neurodiversity as simply a condition. The condition itself may or may not create functional limitations on that person's ability to succeed in the world on their own terms. And in those cases where there are limitations on someone's capacity to succeed in the world on their own terms, we may call that a disability. But for many people who are neurodiverse, the disabling aspect of that is not necessarily because of the way they function, but because of the way the environment reacts. I actually had a conversation recently with a young woman, an autistic young woman, who was telling me about some of the things that are very commonly associated with engaging behavior in relationships that drive her nuts. So, for example, she hates getting flowers because there's something about the dead flowers that really touches her deeply as a neurodiverse person. Hugs, and again, we know that sensory issues are really critical in many people with autism. She's like, I can take a short hug, but a long hug, I start to get anxious. And so, she really helped me understand some of the individualized issues that, again, often associated with, and I don't even want to say neurotypical, but what things that are acceptable as typical behavior among the neurodiverse population require a certain amount of consideration, particularly when the person reacts to something that you think you're doing that you think is a generous or a thoughtful action, and they reject that. They're not rejecting it because of you; they're rejecting it because of who they are as a person. And we really want to look into this in terms with the autistic community in particular. What are some of these characteristics? Again, and I'm going to put these in non-pathological terms: unique social behaviors or communication styles, differences in the way they plan or organize themselves in their days, differences in the way they may process information, sensory sensitivities, or in some cases, the desire for sensory input. There's a common pattern in autistics, which we refer to as stimming, self-stimulation. For a long time, self-stimulation was considered an aberrant behavior. Well, in fact, in many ways, all of us, and sometimes will self-stim. Anybody who has their leg moving under their desk right now is stimming. It often helps with concentration. Stimming can take many, many forms, and for some reason, it just sometimes, again, some of my experience with patients, just playing with your hair could be a form of stimming. Often intense focus on specific interests and a lot of variability in skills. It could be exceptional creativity or pattern recognition. And of course, the most common, excuse me, a theme across many what we consider to be typical autistic behavior. There is no typical. Are issues with emotional regulation. And I actually find many of my autistic friends, colleagues, and patients actually have far more empathy than is typically attributed to the autistic population. They just express that deep concern and ability to connect with others in very different ways. So again, knowing these key characteristics, and many of them are tied to the DSM criteria for diagnosis. What are some of the strengths that are typically found with this community? A tremendous attention to detail and pattern recognition. Often, and this is again stereotypical in many ways, musical talents and creativity, but the same. The neurology of music is connected to the neurology of mathematics. So we see the same thing often in other forms of what we call systematizing or the capacity for salience. Strong memory, tremendous sense of passion and dedication. Often a very strong sense of honesty and sense of justice about rights and wrongs. Often a deep connection, empathy to animals, sometimes more than people, but not always. Often non-conforming. We see a lot of gender-related blurred gender boundaries in this community. This is not gender non-conforming. It's just, again, it's not conforming to what we would consider to be social norms. Often very complex layered thinking, and of course, we see a lot of persistent behavior in this. And often, by the way, sometimes that persistence, when it is interrupted, can result in emotional dysregulation. And so with intensely focused, you're taking someone out of that intense focus. The reaction to that often requires some what we would call transition management in that. Hang on, I have to figure out the right button. Lots of words. And again, I did this deliberately for you all to have some background on this. There is increasing understanding of autism as a genomic condition, and there are over 100 genes associated with the spectrum of autism, meaning when they study people who have various degrees of autistic trait. There's a lot of reference often in the literature to levels or functional levels. The autistic community, in fact, doesn't really like those functional levels. After my work with, again, thousands of patients, Breanne as well, they're often a little bit too rigidly categorical. There's not three, there's far more than that. However, interestingly enough, of these 100 genes, there's no distinct patterns or clusters that are associated with the phenotype. So we have these clusters of genes, less than 1%, lately more less than 5%, have similar clusters, and yet the phenotypic expression is very, very similar, despite the fact that it's completely different genetic patterns. So, and one of the things that is very clear in recent data is level of disability is grounded in the specific gene clusters. There was a wonderful paper published a couple of months ago that identified, based on machine learning and pattern recognition, cluster analysis among some data captured by the Sparks Foundation, that identified 4 distinctive subtypes, based on the genetics. Really important as you read some of the literature to understand that those four subtypes are not definitive, they're directional. So these four subtypes were published. Everybody's talking, oh, there's four subtypes of autism. No, there's many more subtypes of autism. This study just happened to identify four very clear subtypes. And again, the authors are very clear that this is about directional. They are starting to, and they even phrase there may not be one autism, there may be multiple autisms. Matt Siegel, who's a very prominent child psychiatrist, actually the author of the autism guidelines for the American Academy of Child and Adolescent Psychiatry, recently published a short article about the fact that while categorizing may sometimes seem limiting, the only way we can really begin to develop appropriate levels of interventions and understand these populations is by doing some categorization. The interesting thing about these genes is we're starting to subdivide some of the phenotypic expression of autism. For example, we know there are genes for systematizing. So the characteristic of autistics to systematize, to line things up, to organize things in order is it in fact has a genetic basis. But the systematizing genes are not associated with the social communication interaction phenotype. So then there's other genes for something called the salience network. This guides attention and social interaction. So in fact, if you've got different genetic expression between your systematizing genes and your salience network, that's really where we start to see our understanding of the difference in the phenotypic expression. Finally, and probably most important for the pediatricians here, there are some very common autism-associated genes for cellular metabolism. So this is not neurologic now genetics. This is whole body genetics. And some of the co-occurring medical conditions that we see commonly in autistics, whether it be allergies or gastrointestinal issues or sleep, is really associated far more with these genomic patterns for cellular metabolism, not the genomic patterns for neurology. This is going to be critically important to us pediatricians as this data becomes more robust and clearer, less directional and more definitive, because it's really going to help us begin to do some of the planning around the idea that autism is not this. It's not that these conditions are co-occurring; they are part of the condition of autism. You know, the fundamental challenge in early childhood, autistic early childhood, is the fact that the ability to sense and respond to information and experiences in the world is the thing that drives functional skills and behavior. You know, we talk about in pediatrics the idea in early childhood of serve and return as being a critical experience for children. Well, the problem with autistics is there is often a challenge to joint attention as a result of the autistic symptoms of behavior, particularly those that are grounded in the DSM-5. And that in itself begins to affect the scope and sequence of development. So not only do we have the primary, immediately disruptive and disabling current state of the child, but because that current state affects social reciprocity and speech and language delay and sensory sensitivities, those in fact then become barriers and have an effect on long-term development independent of the primary autistic symptoms and behavior. So these neuropsychological barriers to interaction with the environment, people, places, and things, actually end up disrupting developmental scope and sequence. That affects emotional regulation and executive function. And now you've got persistent developmental disruption that is amenable to early intervention. So if you're able to, again, not speech and language is one thing, communication is another. If you're able to help a child find a capacity to communicate, even if their speech and language function is limited, even if we're able to support social reciprocity because of that communication, even if we're able to remove or attenuate the disruptive repetitive behaviors, again, some repetitive behaviors are typical to that child, if we'll take a personalized approach to their development, then we're able to actually put this child back on a developmental trajectory that is unique to them. It's not norm-based developmental trajectory. We've removed the barriers, and now they're able to actually have their own personalized scope and sequence because their interaction with the environment is distinctive and unique to them. As a result of this, I and others have disagreed with me on this, but I really do think that autistic children, by definition, meet the definition of medical complexity. Now, we tend to associate medical complexity with all sorts of other challenges, whether they're G-tube dependent, or they have other levels of disabilities, or other more profound genetic syndromes, or severe chronic illness with multiple surgeries throughout life, cardiac or others. But at one end of the complexity spectrum, if we put it that way, there's four characteristics that characterize this definition in the medical complexity community. One is the condition chronic. I think autism meets that criteria. Two, are there functional limitations? Again, autism meets that criteria for functional limitations. Number three, are there significant healthcare resource requirements? Yes. Most children with autism require a multidisciplinary care, primary care, gastroenterology, neurology, others, psychiatry, and others. And then are there significant family service needs? And there's a massive body of knowledge on the profound impact that an autistic child can, not always, but can have on family dynamics and family needs. We know, for example, that employment issues are often different in families with children with autism. We know that work productivity is different. We know there's higher levels of divorce and marital strife. We know there's a significant impact on the siblings. There's a wonderful organization I recommend that you all explore called the Profound Autism Alliance. It was founded in Boston by Judy City, who Breanne and I know well. Judy has a now 20-something-year-old son with very complex, difficult autistic symptoms and behavior. Judy founded the Profound Autism Alliance, but one of the things they've done at the Profound Autism Alliance is they've set up a siblings work group. And it's become a very powerful tool as these groups of siblings come together on a monthly basis to share their stories and support each other through this process. There are a number of social and systemic challenges to the health and well-being. An amazing piece in Health Affairs a year or so ago. I am not the doctor for you. Physicians' attitudes about caring for people with disabilities. This is more about the adult community, but the fact is there's not a lot of training around autism-related standards of care. It's just something to think about as we begin the process of practice and recognizing that the fact that this condition, again, not disability, this condition certainly has, has biopsychosocial implications. As I said, in addition to the diagnosis-related symptoms of behavior, there are other patterns of risks and conditions. There's a list here, very common ones: sensory processing disorder, ADHD is very commonly associated, and actually in the autistic self-advocacy community, they've actually started to refer themselves in terms of this dual diagnosis. A lot of traumatic stress is associated with this community. People don't think about that, but there's growing a body of evidence that the idea of masking, which is how you suppress your individuality to be able to fit in and manage yourself in a neurotypical world, is itself a source of trauma. And then some of the common co-occurring conditions: anxiety, depression, gastrointestinal disorders, seizures, and sleep disorders are all issues that need to be on the pediatrician's pick list. But more importantly is there's, again, behavioral determinants of all of these that we often need some help with in terms of managing. Just some anchors for you here. We're going to go through these pretty quickly. 50 to 70% of children with autism have chronic co-occurring conditions. This slide got all messed up. Again, 2 to 7 times the non-autistic population. 41% of children with autism are on a major medication. Greater than 3 medications range in the, around the 30%. So a third of kids with autism have some form of polypharmacy. More annual problem-based visits, more emergency room visits, more likely to be hospitalized. Medical expenditures 4 to 6 times those. And then children with intellectual disability have almost 3 times higher than children with autism and no co-occurring condition. Just again, that kind of understand where the system fits. I had a conversation with a medical director of a large health system in New York recently about their focus on children with autism, and the response of the CMO was basically, well, it's only 1 or 2% of my population. Why would I do a special program for them? And I reminded, this is a value-based contract with Medicaid, and I reminded them that this 1 to 2% of the population probably was responsible for a significant skew in their utilization and quality measures. And their eyes lit up. You could see, oh, okay. And we started to talk about what it would take to create some standards of care, standard operating procedures for the children with autism in their practice, including, by the way, focusing on some of the behavioral issues in getting health care delivered. Again, back to immunizations and venipuncture and things like that, dentistry. Again, the real costs, preventable burdens on disability individuals and community, health-related disruptions to work and family life. And again, you've got a population that generally is entering adulthood without employment opportunities, without independent living opportunities, all of which, with the appropriate intervention, is in fact largely preventable. Again, starting early really makes a difference. Later in life diagnoses are more complex. Some are able to cope. There's certain developmental transitions. By the way, the elementary school to middle school transition is a significant risk point for many kids with autism because their ability to adapt to their environment is challenged. And we see a lot of symptom exacerbation with that transition. And then, I've got 4 children. I can tell you puberty in and of itself can be challenging, and puberty in the autistic population can be exceptionally challenging. The real big issue is under treatment, delayed access, subordinate treatment intensity, or early termination leaves these kids at risk. I saw a teenager recently, a 15-year-old, who was still not toilet trained. And they were not toilet trained because the parents pulled them out of the behavioral therapy because it was too difficult for them to keep the transition, the consistency going. And in a week in an inpatient environment, we were able to toilet train this child. And again, I'm not blaming those parents. Lives are complicated, but the more we're able to understand and support, we'll talk about this at the end a little bit, the more we're able to understand and support. I happen to have trained under Dr. Stein, who's mentioned here. The idea that rather than focus on diagnostic categories, we want to focus on child-centered domains. This is one of those things I'd like to leave you with today. Obviously the increasing prevalence of autism has stressed our child health systems. I think it's very, very clear that this change is really grounded in diagnostic specificity. I trained in the 1970s. Very, very clear to me that so many of the kids that we called intellectually disabled, or other words, really were autistic and could have benefited from. But the problem is the usual and customary system for the disability community really was not able to achieve some of the aspirational outcomes. So based on that, it was in fact the parents of children with autism were the ones who pushed state governments to provide access to behavioral therapy based on the principles of ABA. This was not, the ABA community was clueless about this, by the way. I know this, I can say this as an outsider. This was almost in many ways imposed on them by parents who were advocating, and they kind of woke up one day and said, oh, okay, we need to grow our ranks as this demand. And I'll hand over to Breanne right now and let her pick up the rest of the hour.
Yeah. Yeah, right. And I think this is so important to identify here, based on evidence of its effectiveness, as Dr. Merahn is highlighting now, as we progress over the last many decades, all 50 states have enacted insurance reform laws that are mandating access to applied behavior analysis therapy. And considering we're all Hoosiers, thought it was important to identify that Indiana was actually the first state to enact such a law, and that was back in 2001. So about 25 years is what it has required for all states to have these kinds of laws, allow applied behavior analysis to be more accessible to individuals on the autism spectrum. And so we've really seen a significant increase in the services that are available to children, to families, broadening into, adult services over time. But without such laws, these services just weren't as available. So we can go to the next slide. I think it's important to provide a little bit more insight into what is applied behavior analysis. So in my introduction, I just gave a little bit of background in terms of what the credential ABCBA is. But let's just kind of pause on this a little bit more. I'm going to make an assumption that in some capacity in the work that you all are doing, because of the increased prevalence of autism cases that you're likely seeing, perhaps you're finding yourself encountering more folks like me with a behavior analytic background, or you're encountering more ABA organizations and providers. But for those of you who haven't, want to just identify this is a type of therapy. ABA, Applied Behavior Analysis, is a type of therapy that uses proven strategies from the science of behavior to understand why is it that people do what they do, and try to understand how people's environments shape their actions. So it can be applied in a whole host of different ways, all with the goal of helping people build skills and improve their quality of life. And really, at its heart, applied behavior analysis is about creating goals that are personal, that respect each individual's uniqueness. I think Dr. Merahn did a really nice job highlighting this earlier as he was talking through, what maybe initially would be seen as a deficit area, as he was talking through, self-stimulatory behavior or stimming. That's just somebody's uniqueness. That can be when we take a behavioral perspective, we can really use those unique traits to our advantage in the way that we're creating goals, creating treatment plans, and things like that. So a lot of what applied behavior analysis does is that it designs goals to make really meaningful, positive differences over the course of an individual's life. So while ABA is certainly best known for its applications to the autism diagnosis, it's also backed by strong research in many other areas as well. So this has been highlighted a little bit, but it's important, I think, to just re-emphasize and know that applied behavior analysis can support individuals with primary behavioral health conditions like ADHD, anxiety, depression, OCD, feeding and eating disorders. And what we all know on this call is oftentimes individuals on the autism spectrum have other comorbid diagnoses that may include any of the things that I just made reference to. So it's important to understand really the broad and kind of comprehensive scope under which applied behavior analysis can be effective. I think it can be a misconception. Probably highlight this a little bit more in a moment, but the misconception with ABA not only can be that it's only applicable to individuals with autism, but that it's only applicable for challenging behaviors. It could be that a medical doctor or an educator might identify this child happens to be on the autism spectrum, and they're engaging in a whole host of maybe aggressive behaviors to themselves or to others, and therefore now we need applied behavior analysis. But really, it's effective in terms of skill acquisition as well. When we see a deficit of certain developmental behaviors and things like that, we want to make sure that we can approach things from the lens of a behavior analytic perspective to help in that capacity as well. So overall, ABA strategies are in fact effective for addressing severe behaviors, like I mentioned, aggression, self-injury, and for supporting individuals with other conditions that need to be established in terms of acquiring skills. So perhaps individuals who have autism and maybe Down syndrome, for example, or Prader-Willi syndrome, dementia, traumatic brain disorders, those kinds of things. I know we're primarily talking about children, so I made mention of dementia, but ABA is really far-reaching and can be applicable to so many different individuals. So in healthcare, ABA can be applied to improve medication adherence, personal care, dental hygiene, diet and nutrition, physical activity, sleep. These are the kinds of things that you all are likely seeing in your patients, of course, whether or not they have an autism diagnosis. But as Dr. Merahn and I were introducing ourselves and I was highlighting the perspective that I personally have and within the organization at UNIFI Autism Care, we're looking at really whole child health, and we're looking at integration not only with behavior analytic professionals, but other medical professionals. We love to lean on you all as it relates to, how is this child doing, for example, with their diet? Is it robust enough? Oftentimes, children on the autism spectrum can have really rigid preferences for food. Only eat a certain color food, only eat a certain texture of food, and that is really going to significantly limit their nutrition intake. And you all know way more about that and how it impacts an individual's health than myself and my colleagues do. So we always want to get your input and what are the things that you're seeing that are going to be deficits more broadly of the child's health and developmental, trajectory in that capacity. And then we can work on integrating some treatment goals to help, for example, increase food preferences, really work on expansion of food. Another aspect of a healthy person is getting enough sleep. And oftentimes children on the autism spectrum can have very poor sleep behaviors. Either the onset of sleep is significantly delayed, or there's wakings in the night that really limits the consistency of the hours of sleep that they get. And so with chronic sleep issues, that can severely impact overall health. It can severely impact the ability for additional progress and learning to occur. So that example being given because if you all, again, have patients where there's significant sleep issues, when you find yourself having the opportunity to partner or collaborate with a board certified behavior analyst or an ABA organization, it's important to highlight those things and determine, is this on the ABA provider's radar? If not, providing your input on those sorts of things so that collaboration can occur. So overall, a summary, I suppose, of the scope in which applied behavior analysis can be applicable. So we can go to the next slide unless you have anything to add there, Dr. Merahn.
Nope, you got it.
Okay, so I do want to highlight then essentially what ABA is not. So there can be several misconceptions. The first one I highlighted a moment ago, but just to kind of highlight that ABA is not just for autism. I think that's the first and foremost to really walk away from this presentation on. Certainly, it's the most commonly used intervention. ABA is for autism. And just highlighting again, well, why would that be? A moment ago, Dr. Merahn and I were highlighting over the course of the last 25 years, all 50 states in our country adopting mandates for insurance coverage for applied behavior analysis as it relates to the autism diagnosis. That's a very large contributing factor to why ABA and autism are so closely paired together. But there are more and more, slowly but surely, states that are advocating for applied behavior analysis to be used as treatment for other diagnoses as well, and to have ABA as a treatment method that can be reimbursed by insurance for other diagnoses outside of autism as well. So that being a factor of what ABA is not. ABA is also not a one-size-fits-all treatment. So each program is and absolutely should be individualized based on the unique needs and preferences of the learning history of the person that's receiving services. So that's really important. That's my job. It's the job of my colleagues to absolutely ensure that we're looking specifically at this individual. What are their strengths? What are the areas for improvement? I think we all know what a significant spectrum disorder autism is. And so if ABA were to design treatment in the same way for every single individual, then we would absolutely be missing the mark in terms of what important treatment goals are. ABA is not only for young children. So certainly early intervention is extremely important as soon as possible after a child receives an autism diagnosis. It's really beneficial for the developmental trajectory for them to get access to evidence-based treatment like ABA. Some children are fortunate enough to obtain that diagnosis early on in their lives, 2, 3, 4, 5, 6 years old, but other individuals don't receive an autism diagnosis until their teenage years or even into adulthood. And so the point here being, ABA is not just for young children. Certainly, if there's a teenager, an adolescent, an adult that you provide services to that has recently received a diagnosis, ABA can be very effective for those individuals as well. Another misconception, ABA is not in fact rigid or robotic. So when applied behavior analysis treatment is implemented correctly, it incorporates really naturalistic strategies, play-based learning, and really compassionate care. So just like any profession, applied behavior analysis is evolving and maturing over time. And so certainly, it's the case that not every board certified behavior analyst or ABA organization is the same. There's certain different ways of implementing treatment, and some folks might implement treatment that feels and looks more robotic in nature, but over time, there's more and more research being done to identify that the more naturalistic our training and our learning opportunities can be, the more beneficial it is for the children that we provide services to, because we really want the therapy that we're providing to individuals to generalize to the environments that they're most often in. We want the skills that are obtained to generalize to home, to generalize to the playground, to generalize to school, to generalize to playing with their friends on the weekends. And so it's important that then treatment doesn't look robotic and rigid. And then the last thing I'll comment on in terms of what ABA is not is that ABA is not outdated or unchanging. So I just highlighted this, I guess, a little bit, but that's to say that the field is really evolving and continually modernizing with our ethical standards, our research, the input from neurodivergent voices guiding compassionate and person-centered care. You know, what's really interesting is that during my introduction, I highlighted that I'm the president of the board of directors for the Behavior Analyst Certification Board. And that particular certification board came into existence in 1998. And so that is only, what now, 27 years ago. So there are nearly 80,000 board certified behavior analysts worldwide, and every single one of those behavior analysts became certified in the last 27 years. And that's a really short period of time when we're talking about, you know, a profession being in place and having, you know, autism mandates and abilities to, you know, work in combination with insurance providers for reimbursement and whatnot. Medicine and the profession you all are coming from is so much more mature than behavior analysis is. So the science of behavior analysis has existed for far more than 27 years, but the actual profession of behavior analysis is quite new. So the reason I make mention of that is because I just want to dispel maybe some misunderstandings associated to, you know, ABA is outdated or it's unchanging. We're just evolving as a profession, and the more research that we have, the more we can mature and evolve even more. So we can go ahead and go to the next
Just two
slide.
quick comments. One is especially for those of you who are interacting with the ABA community. I mentioned before the idea that the nature of treatment should be based on child-centered domains. That's a question you can ask. You know, how are you doing your assessments? If the treatment plans are grounded in an assessment, then they're not grounded in a child. So how do you take the assessments and convert that into domains? The other piece about young children, I spent 2 years working with the adult IDD community in New York recently in the last 3 or 4 years. And we used behavior analysis with adults. Now, it wasn't reimbursed. It was the IDD programs actually hired behavior analysts, full-time members of the staff, in order to support the people that they were caring for. You may hear, particularly from payers, that ABA doesn't work in older children, and that's an issue in terms of their capacity or willingness to support a treatment plan for an older child, not necessarily based on the science. So, next slide for you.
Yes, thank you. So here, transitioning to talk a bit more about how the science of behavior is applied to the tier of developmental consequences. So, functional communication for nonverbal children, it's really important. And I guess I can pause for a second there for nonverbal children. So it can't be emphasized enough what a broad spectrum autism is. Some children are nonverbal, non-vocal, don't speak words. Other children speak words very fluently and can hold conversations. And, just based on communication, maybe one wouldn't be able to identify that there's a deficit there. But it's important to identify that children with autism who are nonverbal oftentimes do engage in some maladaptive behaviors, maybe aggression, self-injury, and applied behavior analysis can help in this area by teaching functional communication replacements. So oftentimes the aggression is a form of communication in the sense that when a child aggresses to oneself or others, their environment changes in a way that kind of works for them. They may gain access to something that they didn't have access to before. They may gain attention from a caregiver or a peer in some way when they engage in these kinds of behaviors. So a big component of what behavior analysts do is work towards identifying what are some functional ways that this individual can communicate so that they don't have to use aggression, for example, in order to meet their needs. So it's both looking at communication strategies while also simultaneously lessening any maladaptive behavior that might be demonstrated. So we're always looking to systematically establish prerequisite learning skills. Many children with autism lack foundational behaviors that are necessary for learning. A lot of times children are developmentally delayed. Dr. Merahn focused on lack of maybe joint attention as a significant building block skill. So regardless of the individual's age, whether we're working with a 2-year-old or a 12-year-old, if that individual hasn't demonstrated joint attention, that's a very big prerequisite skill that we're going to focus on and build upon that. Another really big foundational skill is imitation. Can I engage in a behavior like clapping, for example, and have that individual that I'm working with imitate me and clap as well? It probably is a little bit lost on all of us how much we rely on imitating the behavior of others to function appropriately throughout our lives. If we think about young children, typically developing children in elementary school, if the teacher gives an instruction, I need everybody to turn to page 7, maybe the child didn't hear the instruction from the teacher, but they look over to their friend, oh, my friend is getting their book out and they're flipping to page 7. Okay, I'm gonna imitate what they're doing and kind of follow along. We're using our environment and the behavior of other people all of the time by using our generalized imitative repertoires. And so that's a big foundational building block that we help individuals that we work with acquire. We really want to focus on a quantitative analysis of behavior to determine function and treatment response. So ABA is very, very function based. What is the purpose of the various different behaviors that an individual is demonstrating? Is it to gain attention? Is it to avoid specific tasks? Is it to access items? So what we do is very data driven, and it's a very individualized approach to ensure that for this specific individual, if the function of the behavior is attention seeking, then we're going to intervene very differently than perhaps this other individual who's engaging in a very similar behavior, but it's for avoidance of a specific task. So we're always looking at what is that function of behavior, and then we're adjusting our strategies as we need to. So we're also looking at through applied behavior analysis and the implementation of these techniques to construct developmental trajectories. That's really our objective here, is for children who are not developing as quickly as their same age peers, their trajectories are getting more and more disparate. They're falling further and further behind their peers. And so the things that we're doing by establishing joint attention skills, establishing imitation, by establishing these building blocks, by looking at the function of behavior, is all with the intent to help them get on that, get back on, I guess, rather, that trajectory for the development as their peers are. And we always want to aim for generalization of the skills that we're teaching. So you all likely have encountered, or will perhaps in the future encounter, the ability to collaborate in some capacity with ABA providers. A lot of times services are provided in a center-based setting, so a clinical setting where the child attends for a certain number of hours a day or a week, and it's pretty purposefully constructed to be free from distractions, or fewer distractions than maybe a typical environment within a school setting, or even at home there's a lot of distractions. And that's oftentimes purposeful, to eliminate those distractions in a really clinical setting. But the intent is always to gradually increase the distractions, to increase the naturalistic way in which a child is learning, in order for generalization to occur. So for the skills that are being acquired, not only to be demonstrated in that clinical setting, but also at home and in school and all of the places that children go. So I'll just comment on a couple of more things related to targeting core deficits by teaching foundational skills. So applied behavior analysis really systematically identifies and addresses deficits in, we've talked about communication, but also social interactions as well, and adaptive behaviors. So social interactions, children tend to, not always, but tend to avoid interacting with other people, or maybe just don't prefer interacting with other people. And that can be detrimental to their development, because as humans in this world, we have to really rely on interactions with each other to be as successful as possible. So it's looking at, again, identifying the function of why is it maybe aversive for this individual to interact with other same age peers? Why is it aversive for this individual to interact with their siblings, for example? And Dr. Merahn was referencing some organizations that have been developed over time, where sibling groups and things like that. Siblings are amazing, and I've worked with so many siblings in the past who are so compassionate and so interested in helping their brother or sister really develop. They oftentimes kind of become sort of secondary therapists themselves, and really, submerge themselves in the progress that their brother or sister is making. And there's just really fun ways that we can make learning very engaging for the siblings. And then lastly, I guess within this content, highlighting the data-driven aspect and the responsiveness to progress that we're always looking for within behavior analysis. So treatment plans that we're developing, and ideally with collaboration with professionals like you all, are guided by continuous data collection and analysis. We're always wanting to make clinical decisions based on what the data is telling us. And it really allows clinicians to make real-time adjustments to teaching methods and to targets, ensuring that the child's learning trajectory is both effective and efficient. So we love working with medical professionals like you all, who value evidence-based treatment and data collection as much as we do as behavior analysts. So I think it's important to know that if you find yourselves interacting with a board-certified behavior analyst, they're oftentimes going to have a lot of data in their back pocket to demonstrate whether or not an intervention is effective, not effective, if perhaps a medication that the child is on is proving to be effective or not effective. And so those are kinds of things that it's really beneficial to collaborate interprofessionally on, is the data that we have. So we can go to the next slide. This one is just a bit of a summary and overview of what let me see if we've got, yep. Okay, so how it works practically.
Yeah, I think the next one is more practical. Can we skip ahead?
Yeah, go ahead. Mhm.
There we go.
Okay, so yeah, and I can go ahead and start this conversation. And I'm sure Dr. Merahn, you have a lot to add, but here, this image, it's a lot, it's overwhelming, but what this illustrates is all the various steps involved in accessing ABA treatment. As many of you know, getting patients the services that they need, isn't just about identifying the right therapy, but it's about navigating the system that surrounds it. And that can oftentimes be the hardest part for everybody involved, not just mom and dad, but you and I as the, care professionals. But because of the way things are structured at the legislative and payer levels, accessing ABA services isn't as simple as writing a prescription on your end. There's multiple gateways along the way, administrative barriers that can slow or unfortunately even stop care. And so, for example, there are diagnostic barriers. We simply don't have enough qualified professionals to meet the demand for autism evaluations. But then, even when a diagnostic report is in hand, the families can face eligibility barriers. So some ABA providers won't take patients based on age or functioning level or other criteria. And even when a family finds an ABA provider, the approval process can be pretty cumbersome. So we're talking about prior authorizations just to conduct the initial assessment, and then another prior authorization to actually begin treatment. So the result can be a pretty long and stressful delay for families, and it's often, missed opportunities for early effective intervention. And so that's, all of these things are why, we all need to really work together. So physicians and behavior analysts and other healthcare professionals is to help these families bridge these cumbersome gaps. So your voice and advocacy can make a big difference in helping families move through these barriers and get timely access to care. Go ahead, Dr. Merahn. Did you want to add
Well,
anything?
no, you started it, so I thought the idea is, and again, in my experience, if you write a prescription for OT, PT, or speech, you're pretty confident that the referral get made and the person goes in. There are two levels of prior auth that's required for ABA. There's again some staffing issues, particularly in rural areas where there may be lack of access. Breanne mentioned some centers do set their own limitations in terms of the patients they want to take. It's an issue that Breanne and I struggle with. But the fact is, we'd love for the pediatric community to get a little bit more involved after the referral, to check in with their families to make sure, did you get that diagnostic appointment? Or if the diagnosis has been made, are you able to access services, to know the ABA providers that you're going to make you can actually ask, to your patients, did the provider ask what your goals were for therapy? Were those goals included in the treatment plan? Do the parents understand that continuity and consistency is really important with ABA? This is not a thing where you can take the summer off, for example. There's often regression after a December school holiday. There can be regression. Again, the other mandate that most payers put in place is an every 6-month reassessment process, which can be very burdensome for families. They require reassessment and another treatment plan. Knowing those plans, knowing that cycle can really be helpful. And then, if you've got treatment goals that are involved with behavioral issues, whether it be some of the co-occurring conditions or medication adherence or medical procedures, push to have those included in the treatment plan, because that supports your goals for overall child health. With that, I think we have a minute or two. I'm sorry we talked on. I'm going to stop sharing the screen. Let's see if there's anything in the chat. I think I saw one. I found that ABA centers in the area only see. It is true, unfortunately, the mandate for payment is really only in the autism space. There's a number of states where it's expanding a little bit. We'd like to see it expanded more. We do believe that with a little more advocacy on the pediatric community, that this access to the science is really valuable, particularly as we all move into, whether it's a patient-centered medical home or other value-based approaches to care where, you know, hitting quality measures, ensuring appropriate utilization, reducing preventable or avoidable emergency room use are all valuable, not just to the payer, but also valuable to the family and the pediatrician as well. So that's the only ping I see in the chat. You know, Breanne, I thank you all for coming today. We're available for other conversations any point in time. And I'm gonna turn it back over, and we can close up.